Here you have my disclosures. And let me start with the definition of aging. As you know, aging is a process of becoming older, and it represents the accumulation of many changes in our organism, in our bodies, including physical, but also psychological and social changes. So this is the first point that I would like to remark about aging, because it's important to think about not only physical changes, but also in psychological and social changes in our elderly patients. And another important point about aging is that this process starts at 30 years of age. 30 years of age. This means that this is the moment of maximum vitality, and after that, the probability of death increases twice every 8 years. Then the aging is one of the main reasons or the main factors of diseases, comorbidities, and also the main risk factor for death. In addition to these important and very important implications of aging, another important point is that elderly people, the number of elderly people around the world is increasing because population is aging. Here you have an estimated numbers, the number of people, the percentage of people aged 60 years of age or older is going to double. And this means from 12% to 22, almost 22% in 30 years. So this means 1 in every 4 or 5 of us are going to be 60 years old or over. Here you have the population pyramid in Spain, but I think that it should be similar around the rest of Europe countries. And you can see here the increase of the mean age in our population. This means that in the last 50 years, this pyramid has changed a lot. And this is because the life expectancy has increased a lot in the last century, mainly in women. Here you have the life expectancy in women, 62 years old of age, and in men, 75 years of age. This means that 60% of our elderly people are women. And this is because the risk of mortality, the prevalence of mortality is higher among men because of professional reasons, more dangerous jobs, for example, because of unhealthy habits, more users of drugs, tobacco and alcohol, and some social customs, for example, being married. Being married is a protective factor, so yes, it's true. And so if you are not married, you have to find a partner, and a stable partner. This is the protective partner. So, being serious, at 75 years of age, we have 1 widower in every 4 widows. This means that in our population we have men, usually married and living at home, and more women, usually widows, living alone or in care centers, in care homes. So it's important, another important point to remark about aging. What are the mechanisms of aging? Inheritance is the main factor because longevity is inherited in 90%. And as I said, females has a longer longevity. The remaining 10% so is associated with external factors, for example, diet, exercise, infections, radiations, drugs, food, etc. In general, aging means the loss of the function of many cells of our tissues, and consequently the clinical consequences. The typical characteristics of aging at the cellular cells are oxidative stress, the shortening of telomeres, changes in nuclear structures, in damage in DNA, in damage in mitochondrial DNA, the accumulation of senescence cells, and also an accentuated inflammatory response. And in our organisms, we have more frailty, more sarcopenia, more tumors, infections, cardiovascular diseases, osteoporosis, etc. In more detail, at cellular level, cellular aging means the accumulation of old cells and also senescent cells. It's not the same. For old cells, these cells lose the ability to proliferate. The reverse, maintain the ability to proliferate, and we have an accumulation of damage in the DNA because of the reduction in proteins responsible for the reparation of for repairing this damage. And we also have an increase of chromosomal reorganizations and a shortening of telomeres. When this damage is not well repaired because the cell loses the capacity to repair them, or when the length of telomeres is critical, then the cell dies, and in this case it's apoptosis and the cell disappears, or the cell entry in a senescent state. This means that the cell loses, in this case, the cell loses the ability to proliferate and start a secretory phenotype, a pro-inflammatory state in the cell and around them. This process is necessary and it's very important because this process avoids the development of tumors and promotes the removal of senescent cells to repair these tissues using the immune system, the immune cells. But with age, this process becomes inefficient and then paradoxically starts or promotes the development of tumors and the aging. What happens in the immune system? Well, the same. The immune system is like other organs, and over time, with age, clinical and subclinical infections, the exposure to antigens, foods, drugs, as I said before, increase the consecutive divisions of cells, the immune cells, and the differentiation of these cells, and then induce the shortening of telomeres. So this means senescence. This is one of the reasons of the senescence. In this case, in the immune systems, we call immune senescence. And the cell loses the ability to proliferate and start a secretory phenotype, a pro-inflammatory state that in this case related to age we called inflammaging, and increase the susceptibility to infections, tumors, and immunological diseases. What happened in HIV infection? Is the aging accelerated? Is aging accentuated? Well, as you know, HIV infection is associated with inflammation. That we know that levels of markers of inflammations are very higher at the beginning without treatment in HIV-infected patients. With treatment and the viral suppression, we achieve lower levels of inflammation, but these levels are always higher than in uninfected controls. Multiple reasons are responsible for this inflammation. As you know, the HIV replication in some reservoirs, some toxicities, antiretroviral toxicities, lipodystrophy, the increased prevalence of traditional risk factors like the diabetes, the increased prevalence of co-infections like cytomegalovirus, hepatitis B and C, or microbial translocations are some reasons of these increased levels of inflammation. So in our patients, we have some antiretroviral toxicities. We have the inflammation related to the HIV infection, and in our elderly group, we have also the inflammation related to aging, the inflammation. So it's logical to think that we have a double dose of inflammation in these patients, and so it's logical to think that these patients have more morbidities, more diseases. What do we know about the basic mechanisms, the basic research? Well, as I mentioned before, here you have some of the mechanisms involved in the aging process. With respect the genomic instability, the damage of DNA and the capability of the cells to repair this damage, we don't have any data about this process in HIV-infected patients. My group is starting working on that. I think that it's very important to know about it. What about mitochondrial dysfunction? We know that some drugs, mostly previous drugs, former drugs like didanosine, like estabudin, are involved in mitochondrial dysfunction. What about telomere length? So we know now that HIV infection is associated with a shortening of telomeres, but mainly, probably, maybe in those patients with a lower levels of CD40 cells. And also we know that HIV infection is involved in a higher levels of oxidative stress. But we have scarce data about that, and we need more data because most of these studies have included a small number of patients, and we don't know, we need to know more about that. What about clinical research? Well, we have many cohorts, aging cohorts, including HIV-infected patients. Here you have some examples in Europe, but we have more around the world. Dr. Reis is leading the Amsterdam cohort, the HIV cohort. We have the JEPO cohort in Italy, the POPI cohort in UK and Ireland, and we have more. And all these investigators agree that the prevalence of most of comorbidities are increased among HIV-infected patients in comparison with uninfected cohorts in all of them. Here you have also some example from the cohort of San Francisco about the increased prevalence of some geriatric syndromes also in HIV-infected patients. We started our own cohort 3 years ago, so it's a small cohort for the moment, including patients aged 50 years old or older, and also including controls and infected patients matched by age and gender from a primary care center near the hospital. We are conducting a comprehensive and multidisciplinary geriatric assessment, and we include medical variables, psychological variables, functional variables, social variables, and also we assess the geriatric syndromes and physiological habits. And with a DEXA scan, an X-ray, as a group of patients, we have the immunological characterization. Well, we are including more patients, but the first analysis, preliminary analysis, we find the same results than other cohorts. A higher, the black bar is HIV-infected patients, and the other one is the controls. And as you can see, we have higher percentage of patients with at least one comorbidity, higher percentage with 3 or more comorbidities, with dyslipidemia, with osteoporosis, with liver diseases, and also a higher percentage of cancer and cardiovascular disease, but without reaching significant statistical significance. And also we find a higher percentage of patients with at risk of frailty in this small group. However, it's important to remark that the differences were seen in our group only in those patients who were 70 years or older, not in the youngest group. From 50 years to 69 years, we didn't find differences between HIV patients and controls. And we found these differences among those 70 years or older. Another important findings are the high, in my opinion, the high percentage of people HIV-infected patients and controls also, almost 20% with an unsatisfactory social environment. Other important point is the higher percentage of people, HIV people living alone, and lower percentage of married people compared to the controls, and a higher percentage of people receiving polypharmacy, 5 or more drugs, in addition to antiretrovirals. And the last interesting finding was that even excluding those smoker or ex-smoker patients, this means, we repeat the analysis only including those patients who never smoke, differences were also seen. So we try to avoid the negative effect of tobacco in this cohort, and we also saw differences between both groups, controls and HIV-infected patients, regarding to the number of comorbidities. So, in my opinion, aging is accelerated, yes. No, sorry, it's accentuated, yes. I think that we have enough data to say that our patients have more comorbidities than controls, but in my opinion, I don't know, I'm not sure if this process is accelerated. According to our data, it's a very small group, it's true, but we saw these differences only in the oldest subgroup of these patients. And I really think that this is going to change. The aging, the accelerated and probably accentuated aging among our HIV-infected patients is going to probably will disappear in the next year, because the new generation of patients have been diagnosed earlier, have started treatment very earlier, and have started safer drugs. So probably, and we have treated also hepatitis B, hepatitis C. So I think that this process are going to be similar to general population. What can we do to avoid this accentuated aging? Well, there are many groups working on new strategies, on new targets. For example, the senolytic therapies, and the objective of these therapies is to kill the senescent cells, like chemotherapy. Here you have two examples, two molecules, but there are many others in development, and the objective, as I said, is to reduce the number of senescent cells in our tissues, to repair these tissues. Meanwhile, because we don't have these drugs, we should offer the more appropriate management to our patients, treating the comorbidities and avoiding the polypharmacy if is possible, assessing the functional and also the geriatric syndromes and treating them using the most appropriate nutrition, promoting exercise, aerobic and resistant training, treating the cardiovascular risk factors, and also, if necessary, with vitamin D supplementations or hormones replacement, like testosterone, for example, but never avoiding to assess the social and also the psychological and mental problems. That's all. Thank you very much.